Okay, let's jump right into this explainer and decode the highly technical and honestly somewhat frustrating rules surrounding time-based E&M coding and the massive friction between CPT and CMS prolonged services. Look, if you're dealing with the 2021 and 2023 E&M updates, you know the original goal was to reduce administrative burden. But when it comes to billing for extended time, yeah, the AMA and Medicare essentially created two completely different math equations for the exact same clinical work. So today, we're clearing up all that confusion.
Here's our roadmap for this explainer. 1. The time-based framework. 2. Qualifying versus non-qualifying activities. 3. CPT prolonged service codes. 4. CMS Medicare threshold rules. And 5. Top audit red flags. Let's get to it.
Starting with Section 1, the time-based framework and calculating total time.
So the absolutely crucial point here is that total time relies on the exact calendar date of the encounter, period. It's a combination of both face-to-face time with the patient or family and the non-face-to-face work personally performed by you, the physician, or QHP. But remember, the clock is strictly bound by midnight to midnight on the actual day of the visit. So if you spend 20 minutes reviewing a highly complex patient's chart the night before, well, that time legally cannot be added to your total time on the date of the encounter. It's got to be on the exact calendar date.
Now, keeping these standard time thresholds for office and outpatient visits in mind, the golden rule before we even touch prolonged services is that you have to completely max out the base code first. Prolonged codes only activate once the time for the highest level base code, like a 99205 for a new patient or a 99215 for an established one, is totally exhausted.
Which brings us to the famous rule of 15. When you enter prolonged services territory, the traditional CPT midpoint rule, throw it out the window. It absolutely does not apply here. You can't just bill for a prolonged service if you've only hit 8 minutes of an extra 15-minute block. No way. You literally must hit the full, complete 15-minute increment to trigger that add-on code.
Moving right along to Section 2, qualifying versus non-qualifying activities. Let's start with the green light activities. These are the specific, countable tasks personally performed by the physician or QHP that you can legitimately log towards your total time for that day. We're talking about prepping to see the patient by reviewing tests, taking the history, doing the exam, counseling and educating the patient or family, ordering meds or tests, documenting in the EHR, independently interpreting test results, and coordinating care. As long as it's you doing it and it's on the same day, it counts.
But you have to carve out these non-qualifying activities. Time spent by your clinical staff doesn't count toward provider total time. Travel time? Out. General teaching that's not specific to patient management? Also out. And this is a big one. Time spent performing separately billed procedures or tests, like a wound debridement or an EKG interpretation, must be completely subtracted from your EM time. Double dipping here is a massive compliance risk, so definitely avoid it.
Okay, Section 3, CPT prolonged service codes.
The exact AMA wording actually proves our rule of 15. If you look at the descriptor for code 99417, it explicitly states each 15 minutes of total time beyond the required primary service time. The full 15 minutes is absolutely mandatory here.
And the CPT system neatly splits these add-on codes by the setting of care. Both require an additional full 15 minutes. But CPT 99417 is your go-to for outpatient, office, home, or residence cognitive assessments and consultations. Meanwhile, CPT 99418 is strictly dedicated to inpatient, observation, and nursing facility care. Seems simple enough, right? Your base code plus 15 minutes.
But wait, what happens when the patient sitting in your exam room is covered by Medicare? Oh boy.
Welcome to Section 4, CMS Medicare Threshold Rules. Let's see how CMS essentially outright rejects the AMA's CPT rules, demanding a completely different calculation.
This table right here exposes the stark divergence. Let's trace the established patient column for a Level 5 visit, code 99215. According to CPT guidelines, you hit the required primary service time at the minimum of that time range, which is 40 minutes. Add 15 minutes to that, and you can bill CPT 99417 at exactly 55 minutes. But Medicare? They require 69 minutes for the exact same visit. Why?
Because CMS argues that the base code isn't actually complete until the maximum time range is exhausted. For 99215, that maximum time is 54 minutes.
Add a full 15 minutes to that and boom, you land at 69 minutes. So commercial payers using CPT rules say minimum threshold plus 15, meaning you bill at 55 minutes. Medicare says maximum threshold plus 15, making you wait until 69 minutes. Guys, that is a 14-minute gap of unpaid time if you aren't tracking your math based on the specific payer.
Because of this massive disagreement, CMS created their own HCPCS Level 2 codes. You literally must swap out the standard CPT 99417 and 99418 for these specific G codes when submitting traditional Medicare claims. G21210 is your absolute workhorse for the office and outpatient setting, as well as cognitive assessments. Then you have G0316 for hospital inpatient or observation, G0317 for nursing facilities, and G0318 for the home or resident setting. If you submit a CPT prolonged code to Medicare, it's going to be instantly denied.
Let's wrap it up in Section 5, Top Audit Red Flags.
Auditors are actively hunting for these compliance triggers. First, if you are rounding your time, like writing spent 40 to 50 minutes, you're going to fail the audit. You have to document the exact total time in minutes. Write spent 47 minutes. Second, if an auditor sees clinical staff time lumped into the provider's total time, or time double counted for an EKG interpretation that was billed separately, they will recoup that money. And finally, as we just saw, crossing your wires and submitting CPT codes for Medicare prolonged services instead of the required G codes is an automatic compliance failure.
So I leave you with this question to evaluate your own practice. Are your time logs strictly audit ready, or are you accidentally leaving hard-earned revenue on the table because of payer confusion? Getting this exact documentation right is the only way to safeguard your practice while ensuring you are fairly compensated for the extensive time you spend managing complex patient care. Don't forget to like, share, and subscribe to Decode Healthcare with Harshal.